This didactic content is intended for global training and educational purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws, or regulations that might apply to use and operation of this device. For this reason, please review your country's current indication for use as provided by the respective regulatory agency. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professional. Individual healing times, discomfort, treatment results, and satisfaction can vary. Please discuss these as well as risks and benefits of this procedure with your qualified healthcare professional to determine whether this procedure is appropriate for you. Introduce our speaker for tonight, Meghan Murphy, registered nurse and clinical consultant for Candela.
Hi, everyone. Happy Thursday. Thank you for having me. Thank you for joining. I know this time frame can be a little rough, especially for our East Coasters, but thank you so much for joining. So we're going to talk about one of my favorite devices ever, the Nordlys. So the Nordlys has technically quite a broad variety of applications. So you have your selective waveband technology, and this refers to your IPL handpieces. Now, one thing that I do think is really important that I have to say I didn't fully understand how important it was until I was no longer using the device every day is the fact that the Nordlys has selective waveband technology. So basically, in my opinion, it's as close to a laser as you can possibly get with an IPL system. So because of the way the energy is delivered and the bands of light it offers, you find that you have a really great clinical endpoint on pigmentation, vascularity, and hair removal. I will still hold true to this. If you are a large practice and you are doing, and hair removal is one of your main sources of income or main patient drivers, always consider the GentleMax Pro Plus. That's still going to be the #1, but this would be a close second. And then we have the Frax 1550 and the Frax 1940. Now, those are your two laser applicators on the device. And basically think of your 1550 as going a little bit deeper into tissue, and think of your 1940 as going more superficial into tissue. So you're going to be able to target deep skin resurfacing with the deeper wavelength, and then with the more superficial wavelength, the 1940, you're going to be able to target that really stubborn pigment. And I can honestly say, the more that I practice, the more that I see a lot of the lesions that I come across are not your standard BPLs. So as long as you're working, I actually work with the derm. So if someone comes to me, we have a very nice agreement. I refer them to a dermatologist. The dermatologist does a skin check for me and then actually sends them back. So if there's anything that's raised or something that I'm concerned about, or they haven't had a recent derm check, I'll send them out to derm and then bring them back in, and then I'll treat them. Now your 1064 nanometer, that's another laser applicator. And with your 1064 nanometer applicator laser, think about this one as treating your darker, bluer, thicker veins. Potentially, it can also treat nails and wart treatment. So you're going to be able to treat toenail fungus or finger fungus. If you do that, please make sure that you have a buffalo filter and a mask, and same with warts. And basically the mechanism of action with that is just the hotter you get those lesions, the more you're able to damage the blood supply that feeds the lesion and or kill the fungi inside of that. So it does work very well. Overall, it does have 22 FDA cleared indications, and my absolute favorite treatment of all time that I really try to get everyone to do is the light and bright treatment, which is going to address pigmentation, vascularity, and skin resurfacing. So not only are you going to get the effect of clearing the reds and the browns, you're also, I swear, you're able to get a CO2-like response in as little as 3 to 4 sessions with the Frax. And that's just in my own personal opinion. I've used it multiple times for that, and I've always been very happy with the result. Okay, so when we're talking about selective waveband technology, and again, this is something that I did struggle with. I've learned it really well over the last year or so. But when we're talking about selective waveband, what that essentially means is you have a filter on the superficial part of the spectrum and a filter on the deeper part of the spectrum. So when we're talking about that, what that means is that we are able to filter out unnecessary light. So just think of this as the shallower the wavelength, the more absorbed by melanin. The deeper the wavelength, the more absorbed by water. If you are using a system that has a very broad spectrum of light, so let's say 400 to 1200 nanometers of light, you have to be thinking, okay, so I am losing some of this energy, my joules, I'm losing some to the superficial portion of the spectrum, so I'm going to hit more melanin, which potentially makes that risky and darker skin, so just something to think about. And I'm losing energy in the water-based part of the spectrum. And so when you have that, so let's say you're using 7 joules on a system that goes 400 nanometers to 1200 nanometers. When you look at the way that the energy is being delivered, it's roughly about 20 to 30% less is actually being delivered into the target that you want to deliver it in. So example, I find that I'm in the Northeast and I find that 98% of my patients have redness. Well, I'm not able to target redness as well with a system that uses a broad spectrum of light, nor am I able to target pigment, which is really frustrating because basically what happens is as you're treating the pigment, you're having so much water absorption that although it looks like you're going to have a great clinical endpoint, so the pigment does turn kind of reddish brown, it's really just more erythema. So just something to note. But the water filtering does make a huge difference. Now, the other thing that I love about the Nordlys, and I figured this out when I was treating, was the ability to tailor your pulses. So a lot of systems, even though it looks like you're delivering 8 joules over a single pulse, you're actually delivering 8 pulses broken up into sub-pulses. And the reason for that is it's actually really hard for any energy-based device to deliver these energies over single pulse durations. Now with the Nordlys, you are able to tailor that approach. So you can use an individual pulse setting, or you can use the setting that's the diffuse redness pigment setting, where it takes your total energy and delivers it into 2 sub-pulses with a little bit of a delay in between. So again, when this is just another slide kind of reinforcing what I talked about. And this is the other thing that I also, when I first started with energy-based devices, I will be honest, I really did not take time to look at the absorption spectrum. Whenever you are looking at a device or whenever you are thinking about buying a device, please make sure that you look at the absorption spectrum for the wavelengths that that device offers. And what you want to make sure is when you're looking at a technology, and let's say you're like, okay, I need to find a device that does really well on pigment. Please pull up an absorption spectrum and see where the wavelengths that the device offers that you're looking at buying falls into. And the one thing that the Nordlys has done beautifully, well, there's many things that they've done beautifully, to be honest, but the thing that is really important and critical to practice is the fact that the way they deliver the energy falls exactly where you need it to be within the spectrum. So you're getting great results on individual vessels at 10 joules. When I'm using the competitor system that offers 400 to 1200 nanometers of light, I'm using 20 to 30 joules of energy. I went to the maximum once to get clearance. So just remember that when you're using energy that's delivered in a way that makes sense, right? So if it's meeting the absorption spectrum, if it's hitting the hemoglobin, you can get away with using a third of the energy that you would use with other devices, which decreases things like blistering, hyperpigmentation, and things like that. Okay, so our Frax 1550 and our Frax 1940, they actually have a really high ROI. So I would say in my practice, we charge $1,600 for the equivalent of that per session. I've heard it go roughly closer to $900 to $1,000, but you've got to think you're able to charge the patient, let's just say roughly $1,000 to $1,200 per session, $1,600 if you're on the higher side. And the rollers are $27 $6 per treatment. So that's a huge ROI for your practice. And the reason that I like that so much is because as a provider, when if I meet someone and I'm like, oh gosh, you would benefit from both the Nordlys IPL and the Nordlys Frax, I really try to, do my best to get them to do both. And when you have a system that has a decreased ROI or a decreased consumable, you're able to kind of work with the patient on the pricing a little bit better. The other thing that I love is because of the way you're rolling the roller and because the actual where the roller attaches to the handpiece isn't bulky, you can really see what you're treating. So for me, what makes a really big difference with my Frax treatments is when I do a full area at 12 millimeters, and then I decrease my scan width to 4 millimeters over individual wrinkling or individual brown spots. And when I do that, I see an absolutely amazing result. So for me, that's actually really important. Some of the competitor systems that I've worked with, I'm not able to visibly see when I decrease my scan width what I'm actually treating. And so I don't see the results on wrinkle reduction that I do see with our system. Okay, so when you're looking at the histology on the 1550 and the 1940, this actually really confused me in the beginning, but you have to think about it like this. When you're rolling the handpiece over the tissue, the handpiece is delivering these little columns of energy. And basically what it's doing is it's heating up these columns within the skin. When you're rolling the 1550 over the skin, it's less absorbed by water. So because it's less absorbed by water, it actually has time to hit the dermis before it's absorbed. So you're able to get your deeper depths with the 1550 because of the fact that it's a little bit less absorbed by water. Your Frax 1940 is more absorbed by water. So it's going, as you're rolling it, it's getting absorbed because what we know is our tissue is like 70% water. So if you have a wavelength that's more absorbed by water, as it's rolling, it's going to start to be absorbed. And so with your Frax 1940, think of that as able to treat anything that's in the superficial dermis to the epidermis. So your benign pigmented lesions. This is not an FDA indication. This is from my own personal experience, but I actually do see an improvement with melasma on it. Well, a couple of things about that, and we can get into that deeper with the case studies, but just some food for thought. Anything like actinic keratoses, again, not indicated here, but I have seen great clinical results on that. Those are the things that are really great responders with these handpieces. Okay, so you can see here, when you're talking about density, think of density as coverage. So if you have a very high density treatment, you're delivering a lot of energy in very small areas. So it's going to be a stronger energy delivery. When you're looking at these wider scan widths, like a 12 millimeter, it's going to take the same energy and it's going to deliver it over a wider beam. And so that means that it's going to be a little bit less aggressive. So the reason that I like that is when I'm doing individual wrinkling, I'm going to go back over each individual wrinkle with the 4 millimeter. I see great results. If I have a really stubborn benign pigmented lesion, I'm going to go over that with the 4 millimeter and I'm going to get a more laser-like delivery. So less fractionated energy delivery, more full beam energy delivery. Okay, so now we're going to talk about the 1064 nanometer wavelength. Okay, so a couple of things about the 1064 nanometer wavelength as a clinician. It is a wavelength that you have to be respectful with. It's a very strong wavelength. It penetrates very deeply in the skin. And one of the things that happens is when you use the 1064 nanometer wavelength and you're treating over a vessel, the first pulse you fire, the hemoglobin inside of that changes to met hemoglobin. So the light hits it, it turns from hemoglobin to met hemoglobin. Once met hemoglobin forms, the energy delivery that you then proceed to deliver has a 20% increased absorption rate. So 1064, you pulse it. It is absorbed by the hemoglobin inside the vessel. The hemoglobin changes from hemoglobin to methemoglobin. When you have methemoglobin formation, you have to remember that every subsequent pulse you fire is going to be absorbed 20% to 30% more. So when you're treating individual vessels, or when you're using the 1064 nanometer, please make sure when you're using energies that are usually you're over 100 joules per centimeter, please make sure that you're skipping 2 spot sizes between each pulse. It's going to allow for the energy to diffuse a little bit so you don't get overlapping of heat, which can then lead to undesired effects. So what's really nice about our handpiece is well, actually, it's kind of amazing. I wish when you use it and you use the 1.5 millimeter, which is what we recommend for the face, the settings are like chef's kiss, as the young kids say. And so the energy delivery works every single time. So when you're pulsing and you're using the drop down setting on the 1.5 millimeter, you fire, vessel clears, fire, vessel clears. It's unbelievable. So that's a really nice thing about the system. And that's something that I actually forgot to mention. So when they created the Nordlys, they worked with it's a very well thought out product, and you can really tell in the way that it's made. But they basically had worked with dermatologists for 20 years, I believe, and captured all their data and then used the data to put the plug and play settings into the system. So it's really, like, in terms of that, it's unbelievable. So when you're talking about the 1064 nanometer handpiece, you can see here that it has all these different, I don't know how to point to my screen, but you can see it has all these different sapphire tips. And so that allows you like an ease of ability when you're treating. You can kind of see the vessel and treat. I do this a lot with leg veins. I will do this on the face if I have tried, which I actually really don't see a ton of. Typically, I'm able to treat pretty much any vessel with the PR530 on the face, but if I wasn't for whatever reason, you can try the 1064 nanometer handpiece. And you don't need a lot of pressure, because remember, when you're treating vessels, you don't need a lot of pressure. Okay, so let's get into clinical considerations when you're treating off of the face. Now, there's a couple of things to note. When you're treating off of the face, you do not have the adnexal structures that the face has. Examples of that would be eccrine glands, sebaceous glands, and hair follicles. So those structures that are on the face actually help the face heal. So you have to remember, okay, I'm treating the chest. The chest does not have the adnexal structures. Not only does it have a slower cell turnover because we're moving down off the face, it also does not have the adnexal structures that the face has. So I need to decrease, typically you want to decrease your energy by 20%. You want to vary your pulse duration. We'll get into that. But typically the reason is because you don't have the adnexal structures to help the area heal. So the first thing you want to think about is wavelength. And so one thing that you really want to consider is when you're talking about wavelength, you want to start with a wavelength off face that is less absorbed by melanin. When it is less absorbed by melanin, it's going to be a gentler energy delivery. Okay. So consider starting the patients with the VL555 applicator first, and then you can always increase to the PR530 in subsequent sessions. It just is an added safety net because, again, that handpiece is not as absorbed by melanin. Now, I will be frank with you. If I have a lot of diffuse redness and it's a lighter Fitzpatrick skin type, so a Fitzpatrick skin type 1 through 3, I do default to the PR530. I just don't see the clearance on the diffuse redness that I see with the VL555. Now, when we're talking about parameter selection for the pulse duration, you kind of want to lengthen your pulse duration when you're treating off the face. So when I'm treating on the face and I'm doing pigment, I typically default to the individual telangiectasia setting because I like the way my energy is delivered with the single energy setting. But when I'm treating off face, I actually tend to default to the diffuse redness pigment setting first, And then if I still don't see my endpoint, then I'll graduate them to the individual setting or the individual telangiectasia setting in subsequent treatments. Now, make sure when you're treating, you always test spot off the face. Now, the other thing that is just really shocking to me is people still to this day, and I don't know if this will ever go away, they are not honest with their sun exposure. And if you're treating the chest, you have to remember that the chest has been like walking to the car. If you have a V-neck on, your chest is going to absorb that light, right? And it's going to make this area darker, and it's going to create a competing chromophore for the laser. So really test spot, test spot, test spot. You really want to test, and I wait like 15, 20 minutes if I can. And I always ask the patient, I pulse once, and then I ask the patient, do you feel any lingering burning or heat? If they say no, usually that's a good indicator. The other thing you want to look at is you do not want to see the beam. So if you're using the VL555, right, and let's just say this is the way the energy is delivered out of that light guide, if you were to treat and you saw a red bar that looked like this, that typically means, I think typically it means that the patients had recent sun exposure. And so basically what's happening is the IPL is not able to tell the difference between the skin you're trying to treat versus the active melanocytes in the skin. So when you're test spotting, test spot, and always use 20% less energy than you would on the face. So when we're talking about the Frax 1550 and the Frax 1940, if the patient, okay, well, let me just be honest here. If it's my way and I have unlimited time, which doesn't really happen these days, but if I did, I would pretty much be using both wavelengths on everyone. Just throwing that out there. The only time I don't is if I suspect there's underlying dermal pigment, or if it's a darker Fitzpatrick skin type, I'll start with one and kind of see how they do and just make sure I don't see anything, and maybe at the second appointment incorporate some. So if you're starting the patient and their main concern is stubborn pigment, then you're going to want to use the 1940. If your patient presents with coarse texture, then you're going to want to use the 1550 at least. And really with coarse texture, the harder you can hit it, the better. So if you could also use the 1550 with the 1940, that would be ideal. Now, your energies are your millijoules, so that translates to depth in the skin. When you're treating areas off face, I really don't go above 40 millijoules. I would try to stay below that, and anywhere from 10 to 40 tends to be within the ballpark of where you want to be. Now, when you're talking about pulse duration, you want to use the shortest pulse duration that will give you the desired energy. So when you're using your pulse duration, you basically manipulate the pulse duration. I just manipulate it based off of the energy delivery I'm trying to get. So just some food for thought there. And then again, areas when you're treating off face, lower coverages. So interestingly enough, when you really do deep digging, and I kind of learned this from our core, your percentage or your coverage is a huge indicator of how aggressive the treatment is. Higher coverages, so like 20% or above, are a more aggressive energy delivery. Anything 30% of above is a very heavy energy delivery. So just some food for thought there. So in a perfect world, your patients avoid the sun, and they do it a lot. That doesn't happen. But if you're doing IPL applicators, they really need to be out of the sun for a minimum of 2 weeks, ideally 4 weeks. The Frax you can push, but I will tell you, even though it's not melanin absorbing, if a patient goes out in the sun, the melanocytes that sit in the epidermis get excited. They're like, oh, let me produce pigment. Let me shield you from the sun. So when you go and treat over that, you already have enlarged, stimulated melanocytes. They're already willing to battle for you. So if you go in and put heat on top of that, heat stimulates melanocytes. So if you go in your heat is going to further stimulate the melanocytes. If they're already aggravated from recent sun exposure, the risk of things like post-inflammatory hyperpigmentation go up twofold. I have problems with this in practice all the time. The patients came in all the way, they want their treatment. So what I did is I took pictures of times where I've had less than ideal outcomes, and I show it to the patient and I'm like, we can treat, but this is potentially what's going to happen. And every time they're like, okay, I'll wait. Now let's also talk about downtime. So the further down the body you go, the slower the cell turnover. So you've got to remember, these patients, if you're treating arms, it's going to take a while for that to flake off or turn over. So one time I treated this woman's arms and it took 2.5 months for the pigment to shed off. She messaged me, she was like, it's not clearing. And I said, try using the Aquaphor spray or the Vaseline spray. She started using that and it totally helped. The more hydrated you keep the area, the faster the cell turnover happens. So what I try to do is I try to say today, just follow standard post care. But starting tomorrow, you want to keep a thin layer of Aquaphor or Vaseline on the areas we just treated, because that will help with cell turnover. And as someone who's had multiple treatments of IPL, every time I use Aquaphor or Vaseline on top of a moisturizer, I have better, faster results in terms of my downtime or in terms of my cell turnover. So when we're talking about diffuse redness, BPLs, and wrinkle reduction, you want 3 sessions spaced at 6 to 10 week intervals. In cases, okay, now the other thing we have to talk about with diffuse redness is most people with diffuse redness don't want to follow the changes in their lifestyle they have to have, which these include decrease your alcohol consumption, decrease your sun exposure, don't work out for 3 to 4 days after the treatment. In some cases, I have seen people who potentially aren't getting their caloric intake correctly. I do think when you're a little bit malnourished, that can also add to some redness. So or smokers, when you smoke, your vessels dilate because they're bleeding for oxygen or burning for oxygen. So when you're treating these patients with diffuse redness, I actually made a diffuse redness document and I send it to everyone when they sign up for redness sessions. If you're not willing to do the homework on your end, you're going to be someone who needs 6 to 10 sessions. And it just is what it is. So you need 3 to 6 sessions depending on the degree of severity, and they need to do maintenance once to twice a year. But if you treat Rob, and Rob has severe diffuse redness and he gets a great response, and then he goes and drinks all summer and smokes all summer or lays out in the sun all summer, he's probably going to need 3 more subsequent treatments when he comes back. So just remember that when you're signing patients up. Same with pigment. Like I can do wonders. I can get rid of every single brown spot on your arm. But if you go and self-tan or if you go and lay in the sun, that's going to stimulate melanocyte production again. Now, the other thing to know is when you want to extend your results, and actually, oh goodness, we had a speaker who did a really good job with the Exceed Academy, and I am blanking. Darcy, gosh, I know her too. Darcy does a really good job at talking in her talk about appropriate post-care. So let's just start from the top. If you're treating benign pigmented lesions, you need to make sure that they are using a sunscreen with a minimum SPF of 30, and it has some kind of titanium and or zinc in it. They need to reapply it every 80 minutes. That is the newest data. If there's, oh, hi, Darcy. Oh, she's there. If you are treating someone, the other thing that's really interesting is you need to, if you're swimming or you're sweating, you need to apply it every hour. So something to note, your sunblock is only good if you reapply it. And people come in and they're like, oh, I'm really good with my sunblock. I put it on in the morning. If you don't reapply it, it doesn't last. The SPF number technically means how long until you have to reapply it. Anything under 30, you really want to avoid. And I think it's up to 70 I don't know if the data shows a huge difference between 70 and 100, but that SPF number actually means how long until you have to reapply it. And it's generally roughly 80 minutes. So just some food for thought. People always think you're really intelligent when you say that, and that's just the way that it is, okay? Okay, so this is like one of my favorite slides. So if you are treating someone, okay, a couple of things I just diverted in my head. But if you are treating someone, let's say you're doing IPLs, not that I don't want to say you don't have to worry about it, but your IPLs are so absorbed by vascular or melanin that when you're treating things like brown spots or redness, the depth is a little bit, I don't want to say not related, but your depth isn't something that you have to think about as much. You do have to think about that with your Frax handpieces. So what I do is when I'm figuring out the settings that I want to use on my Frax handpieces, I actually look at the depth of the dermis and I try to make sure that I'm somewhere in there, okay? So when you look at that, if you're looking at the micron, so let's just say, this is female versus male. So you kind of want to look at that and you want to say, okay, so if I'm at 200 microns or what have you, you need to make sure that your energy delivery is somewhere that's going to hit that. So if you look here at your scalp, you roughly want to be at 111 microns. Now, the other thing that I think is really cool, and again, I have not studied this, and I am speaking from my independent experience, not on behalf of Candela, is I think everyone who's listening, you guys should try to use your 1550 or your 1940 for hair restoration. There is some data that shows that microneedling, the channels that you create are a little bit too small to actually get effective drug delivery. But when you use heat, because it makes a bigger zone, you can actually get a really nice endpoint. So if I were you guys, I would grab my 1550 or my 1940. I would run it up and down someone's scalp. Ideally, they have a good pain tolerance, but you try it and then you do some exosomes in there. And I think that you'd have really nice results with hair growth. So that's just something that I think about. But you can see here, this can help you pick your depth, because what we know is when we're treating wrinkles, we want to be in the deep dermis. And I know there are some, put your earmuffs on. There are some people who, when you're treating, so there are some people who think you only need to restructure the superficial dermis. There are other people who think you need to restructure the deep dermis for collagen production. As someone who's used the handpieces, I have seen great results when I go deeper on wrinkling. So I usually, when I'm treating my 1550 candidates for wrinkling, I usually go at, I'm thinking, I always start around 50 MTZs. So usually their first session is at 50, their second is 55 to 60. If I can get them to 65 or 70, that's what I'll do at the third. This is for my lighter Fitzpatrick skin types. For my darker Fitzpatrick skin types, I typically hover around 40 to 50, depending. And also it depends on how good they are with post-care and if I know they'll stay out of the sun. So just some food for thought. Now, when you're talking about epidermal lesions, right, when you're talking about the 1940, if you're trying to target something in the epidermis, you don't typically need a super deep depth. Now, that being said, the 1940 to me is pretty efficacious with little side effect risk, I would say. So I do tend to go to 20 on pretty much everyone if I'm trying to get collagen stimulation. If I am talking about if you have a patient that comes into your clinic and you're thinking about treating them with Frax handpieces, I actually don't think this is such an issue with the IPL, but if you're trying to treat them with Frax or really, I guess, IPL, you always want to use a Woods lamp or your Visia first. Take the Visia or use the Woods lamp and see if you see any underlying dermal pigment. If you see underlying dermal pigment, that means that you're potentially going to see, when you use too much heat, you could exacerbate it. So kind of make sure that you look at that before and you go from there. So if I see someone with melasma, I use shallower energies and less coverage. Or I'm sorry, not technically with melasma, with underlying dermal pigment. Okay, so then this is the dermal thickness on the body. So again, use this when you're picking your energy delivery. So just something to think about here when you're talking about that. That will be a really good, this will really help you decide what to do. Hopefully no one's treating a newborn with this system, but otherwise this can be very helpful. We have some questions. So Rosina, hi, thank you for asking. When you treat wrinkles with 1550 with the fluence of 50 millijoules, how many passes do you do? Great question. When I am treating wrinkles with the 1550 at 50 millijoules, okay, so what I typically do is it depends on if I'm doing it with 1940 or not. If I'm doing it on its own, it's 4 passes at 50 millijoules, 12 millimeters. Then I go back over each individual wrinkle and I go to 4 millimeters and I go back over each individual wrinkle about 2 to 4 times. Now, I did that to my mother-in-law's best friend and she was quite the pufferfish for like 4 days. So if you decide to do that, you just have to warn them about the swelling potential, especially when you get near the eyes. So something to think about is, if you're going to do that near the eyes, consider using lower energies if you are worried about swelling. And then, hi, Jessica, 50 to 70 millijoules on the face for wrinkling. With the 1550, yes, I do. I do. Hi, Kira. So someone said, did you say self-tanners stimulate melanocyte production? Yes. And as someone who's an avid self-tanner, and has melasma, I can testify to that. So anytime I got a spray tan or anytime I put self-tanner on my face, I would notice when it would start to fade that my brown spots would come out. And there is some literature stating that self-tanning does actually activate your melanocytes. And I even had somebody in a trial that I was doing with the GentalMax Pro Plus at the Candela Clinic, and I had treated them. They had the most beautiful results I've ever seen. They're actually our before and after photo. And then they came back in at their 8-week follow-up or 3-month follow-up, and they had used self-tanner and all the brown spots on their arms came back. So I do tell my clients that it will stimulate melanocytes. Most people, it's transient. I think if you have melasma, it might make it hang out a little bit longer. Hi, Gary. So we have compare and contrast using Nordlys versus BBL with Halo. Okay, so so let's start with the IPL handpieces. The IPL handpieces, because of the way the energy delivery is tailored specifically on the PR530 for vascularity and pigment, you are going to see that when you're with and I could be wrong here, but when I'm using the BBL, I'm using like 20 to 30 joules for individual vessels until I see anything. They will blanch and then they come right back. With Nordlys, when I use the tried and true 1010, 1313, or 1515 settings on the PR530, I clear the vessels, they come back, they're gone. I'm sorry, they come back in the next session and they're still gone. I do not see the pigment clearance that I see with Nordlys, nor do I see the vascularity clearance that I see with Nordlys on the BBL. I personally think there's a lot of water absorption going on there. And so you're losing a lot of energy delivery to that part of the spectrum. There's that. Now, when you're also talking about competitor equipment, when you're looking at the wavelengths, I believe that system you're asking about uses 2940 nanometers as their ablative wavelength and then 1470 nanometers as their deeper wavelength. I don't like those wavelengths. The 2940 is too superficial to me. The only time I like 2940 is if I'm using it fully ablative and I'm going after individual lesions, which again, I still think I get just as nice of results with 1940 when I do that. So just putting that out there. And I think that I also, with the 1470, the difference between the 1470 and the 1550 with actual collagen stimulation to me is game changing. I see a way better improvement on wrinkles when I do the Frax 1550 and the 1940 combination than I do with the competitor systems, and that stands true across the board. The one thing is you've got to work a little harder for that, right? So I do a lot of passes, I decrease my scan width, I go over everything as much as I can, and I do typically 3 sessions, but I can do 3 sessions with Frax 1550 and Frax 1940 because their downtime is not that bad. They're looking at maybe 3 to 4 days of swelling, up to a week of the pigment darkening. The other competitor that you asked about that uses 2940 superficially and the 1470, the downtime with that, I'm looking at about 2 weeks because I think that 2940 wavelength is so superficial. I just don't like, I personally don't like the energy delivery on it. Okay, I'm going to keep going and then I will get to all the questions. So, okay, so, oh, we talked about this. Okay, so now we're going to talk about individual clinical presentations. So when we're talking about vascular conditions, we're talking about anything that's red or that is stimulated by blood flow. Okay, so rosacea, diffuse redness, individual vessels, and poikiloderma of Savat. These are, and this is how I think about this. If your patient comes to you and this is the other thing that's frustrating, and this is a side note about treating diffuse redness, they'll say like, oh, I get really red, and they come to your clinic that day and they're like not red. So just some food for thought. There are things you can do. You can like pinch the skin to get the blood flowing. You can scrub it really aggressively with like a hydrochloric acid on a gauze pad to try to get the blood flow stimulating. You can do those kinds of things. But basically, when you're talking about vascular conditions, you are talking about anything that is caused by persistent flushing of the skin. You'll typically see, if it's poikiloderma, you'll see it here. If it's usually typical, it's here, here, and here. Now, when you're talking about that, that is caused by really small capillaries. So the capillaries themselves are very small. You need a short pulse duration to target those effectively. You're also talking about rosacea. Now, if somebody has really bad rosacea, they actually get hypertrophy of the sebaceous gland because there's so much blood flow to the area, they're able to grow and thicken. So you actually will get that kind of that thick nose from that as well. You really want to try to get your rosacea patients before that starts to happen. They may also have acne, and they may also have a little bit of like a rash type situation. Be a little, I don't remember putting that in about the rash, but be a little careful if the patient has a rash. If it's like a dermatitis-like rash, you actually don't want to treat it with the with anything because you can stimulate it. But if it's that like acneic situation that you see with rosacea, that can actually treat really well. Okay, so again, I talked about this earlier, but please make sure when you're treating your rosacea diffuse redness clients that you sit down and talk with them. They, for whatever reason, respond to triggers by dilating blood flow. So things like sun exposure, coffee, alcohol, extreme temperature, spicy food, exercise, that is going to stimulate blood flow. If you go in and you treat and you close all those capillaries and then they go and do something that reopens them, the results are going to be very transient, okay? So just something to think about. Now, when you're treating individual vessels, so if you are treating like my uncle, which was so funny, we were at Christmas dinner and he was talking about how he went to a dermatologist who treated him with the GentleMax Pro. And he's like, you ever heard of that? And I was like, yeah, I've heard of that. I work with that company. But anyways, if you're talking to someone and you see that they have individual vessels like on their chin, you typically need to be around 10, 13, 15 milliseconds pulse duration. If you're treating what we just saw on this last slide, right, and it looks like little baby capillaries, you typically want to be at 3 or 1.5 milliseconds, okay? Shorter pulse durations are better. Now, on this slide, this is technically poikiloderma of Savat. Now, with poikiloderma of Savat, what happens is you have dilated capillaries that are all matted together and mixed with pigment. So not only do you have the redness, you actually have the pigment in there as well. You will see it on golfers. You will see it on people who live in like Arizona. You'll see it a lot on the lateral sides of the neck. The Nordlys does, like I always treat that and they come back in and I myself am shocked at the results. So just something to note, you want to use shorter pulse durations on that. Now, I said 4 sessions here, and I will say it is 4 sessions with my beloved Nordlys. It's actually could be even closer to 3, but sometimes if they're really not great about their post care, they may need closer to 6 sessions. So just something to think about. Now, there are topicals that you can use post treatment. So you can use something like Rosatrol by ZO that has really nice, not only does it help, and actually Darcy taught me this, who's on the talk, not only does it have really great results in decreasing the redness, it also helps with decreasing the sebaceous gland activity, which is what you see with rosacea a lot. So some food for thought. Oh, the other thing is if you're treating a rosacea client and they have the acne component, consider using the 1940 or the 1550 over the IPL. So when you do that, if you're at the higher energies that you're at least hitting the superficial to mid dermis, I have seen people not have an acne breakout for like 6 months after they do that treatment. It's the only treatment I see it with, either the 1550 and ideally the 1940 or the 1940. I actually think that that heat goes deep enough to actually damage the sebaceous glands. So just some food for thought. Okay, so when we're talking about benign pigmented lesions, we are targeting the melanosome within the brown spot. So what happens is you go out in the sun, you have these melanocytes that sit right at the dermal epidermal junction, and they're like these little octopus situations. The melanocyte sees the sun, it gets triggered to stimulate pigment. It produces pigment via the melanosome. The melanosome travels out through and that was really great. That was whatever. Okay, so it travels out up the arm, hits the keratinocyte, and then moves that keratinocyte with the melanosome move from the middle to the top layer of the skin. So that's kind of what happens. So if we can't stop your ability to produce pigment, and we wouldn't really want to, because that's where you would end up with hypopigmentation. But if you treat Sally and Sally has these amazing results, but then Sally decides to live her best life over the summer in the sun, she's going to need subsequent treatments in the fall because we haven't stopped the melanocyte's ability to produce pigment. All right, we have some questions. We have a question here from Jessica. Treated poikiloderma at max settings with no improvement. Red dot setting drop. Yeah, so Jessica, I'm surprised by that. If you're using the diffuse redness pigment setting, that might be what's going on. What I do for poikiloderma is I mimic my V-beam settings. So the first session I use the red dot, but I actually go to 3 milliseconds instead of 1.5 just to be a little bit safer on the neck. And I use 6 to 6.4 joules. Second appointment, if they were okay, I'll drop down to 1.5 and hover around 6 joules. Hopefully that helps. Also, if it's really stubborn, and I'm hoping I would only use PR 530 on that. I wouldn't use VL 555 unless they were a darker Fitzpatrick. I don't find that the PR does a great job on the redness component of that. Okay, sorry. Hi Maria, I may have missed this, but for stubborn red vessels with the PR 530, do you use expert mode to do equal joules in milliseconds? Yes. So the highest you would go, so if you pick, okay. When you're looking at a vessel, ideally I can eyeball it now, but when I was first starting, I would take my little vein card and I would measure the diameter of the vessel. The diameter of the vessel aligns to what setting you should be picking for your pulse duration. So if it's a fine telangiectasia, which I cannot remember. It's in the user manual. I'm so sorry. I cannot remember the vessel width on that. You use 10 milliseconds, and the highest you would go to is 10:10. If it's a medium vessel, you would do 13:13 highest. If it was a thick vessel, it would be 15:15, and that's kind of how you do that. Oh, hi, Tracy. So what do you mean 10, 10? So 10 joules, 10 milliseconds, 15 joules, 15 milliseconds, 30 joules, 30 milliseconds. So when you're treating and you pick the individual telangiectasia button, and then you go to the next button, it looks like little squiggles. Well, there's a red dot and then there's little squiggles. That will give you kind of those settings. Hi, Jessica. Parameters for hypertrophic scarring with 1550. I read 70 millijoules at 6 mil. Okay, let's talk about hypertrophic scarring. So hypertrophic scarring is basically an overproliferation of collagen production. So, and I have to talk like this because that's the only way that I can like come up with my agreement. So if I see hypertrophic scarring, I always want to hit it with the PR530 first, because you want to coagulate that vessels. You want to kill the vessels that are feeding the blood. So it's going to be, you have to treat those till bruising typically. So it's going to be like anywhere from 3 milliseconds or 1.5 milliseconds, somewhere around 6 joules. Cool a little bit in between, take the ice pack off, let the heat come back to the skin. Then hypertrophic scarring, you have to be a little bit careful with, because with hypertrophic scarring, it means that they have the propensity to build collagen a little bit fast. So I actually don't use the narrow scan width. I typically use 10 or 12 for the first, just to see. I do 10 to 12 millimeters, 70 millijoules, 3 to 4 passes, maybe 2, and then I bring them back in 6. Well, ideally you would do, scars can be tricky. Ideally you would do like 8 to 10 weeks. Hi, Danielle. Can you provide some insight on the best settings for scars on the body? So it kind of depends. Is the scar white or purple? If the scar is purple, you need the PR530 on it. So if it's a darker Fitzpatrick skin type, all right, let me back up. If you're treating purple scars and it's a Fitzpatrick skin type 1 through 3, you need to use the PR530, 1.5 to 3 milliseconds, 6 joules. And then you go up from there. If it's a darker Fitzpatrick skin type and they have kind of that purple nature, you would use the VL555 and you would use the shortest pulse duration that you can. And then you would use probably somewhere around 8 joules starting. Then you would do your 1550 over that. Now, one thing you have to remember is, depending on the body area, where is the dermis and where is the scar tissue? So you need to make sure you're hitting the scar tissue. So you would look back at the table that I have in the beginning, and you would make sure that your depth on the 1550 is hitting where that scar actually is. Hi, Ria, I believe, and that's a very pretty name if I'm saying it correctly. Are there any topicals you recommend applying after fracs for darker Fitzpatrick skin types prone to PIH? Yes. Okay, so immediately after, I would do the Bright Alive by Zio, or this is something Dr. Shallon, our medical director, taught me. There is a topical from Meso Aesthetic, and I can see it in my head. It's a brown bottle and you draw it up in a vial. I would lay that in there. Basically, oral topical tranexamic acid is your friend post-treatment. So if you can find something that has that, that would be a really good thing. In fact, one of the talks I was at, and I have my notes here from that, they were able to get theirs from, they got a special compounded from Mesoteric, Mesoteric, and that's how they were able to keep their results. So just something to note. Can you really treat melasma with IPL? I don't like treating melasma with IPL. I really don't. Okay. Hopefully you all are tuning into Nicole's talk on the Matrix Pro. And not that this is indicated, so my people in the back that are listening, earmuffs, but okay, if I had it my way, I would treat all my melasma clients with RF microneedling with a system that actually gets into the skin, okay? And the only one that I know of right now is the Matrix Pro. So when I see a melasma client, there's typically a vascular component to that. The way the RF microneedling delivers the energy is it heats up here, then it moves up a notch, it heats up here, then it moves up a notch and heats up here. because of the way it delivers these footballs of heat, instead of causing full columns, you will see a drastic improvement in melasma. I have seen it. I have bad melasma. It's really bad on my forehead right now. And I've had RF microneedling done. I had the Matrix Pro, and I noticed a huge improvement in my melasma. Like, I was floored and overexcited. Now, that being said, if you don't have that in your practice, if you don't have the PicoWay and you don't have the V-beam, you can consider using the Nordlys. You want to use the split pulse duration setting. So you want to do like the diffuse redness pigment setting, very low energy. You pulse, you cool aggressively. Then you can use the 1940 on low energies, very low energies. And then you need to use a specific topical post, which would be the mesoteric that I just said, or Bright Alive or something like that. So Darcy has a good point here. If there is a vascular component to melasma, she uses the PR at PR 530 to pull back the vascularity while cooling. So here's the thing we have to remember with melasma is it's really a heat triggered component, right? So if you're doing something to the patient that has melasma, if you cool aggressively post, that can really help. I think Darcy has a Matrix Pro, so like also interested to see how you do with melasma with it, but just let me know. If you kill the vasculature, if you die that down, the melasma is naturally going to get a little bit improved. I actually am lucky because I can work with a derm, so she'll compound stuff for the patient, and then she'll do that for me. There's another pharmacy, if you guys are NPs, that you can call scripts into, which is, I think, STK in Florida, and you can have it mailed to the patient's house, and you can do it with that then. So try that. There's a question here about shaving areas before you do a frax. Ideally, yes, you would. Well, it is water absorbing. It's not really melanin. I mean, the closer you could have it, the better. And for certain areas, I would, like, if I was doing the area I talked about earlier, that whatever, I would go like down the middle, if you know what I mean, in areas where it maybe decrease the scan width a little bit. Okay, so recommended treatment intervals. We went over this already, but just something to note. Yeah, so Darcy's right. So she said you can hit all points of melanogenesis. Just for skip the video, we're going to go over this, and I'll tell you what it Darcy said. So here I am treating an individual vessel. I measure the width of the vessel first. And then I go to my system and I plug and play. I usually use 3 millimeters, and I'm doing this with a softer face. I apply a very thin layer of gel. And then I treat, so I pulse. You can see the vessel darken and or vasospasm. The vessel darkened, you want to press on the vessel, and it will, if it wasn't filling with blood, that's a good indication of the right. Okay, so that was the leg vein treatment, sorry. Okay, so Darcy said you can hit all points of melanogenesis with vitamin C, retinol, and Bright Alive from ZO. I do agree with that, but Darcy, you should see my melasma. It loves to live. It would live, it lives through all of that. So, the point being, if you're going to treat somebody that has underlying dermal pigment, set yourself up successfully and make sure that they're doing the pre-care, okay? That will give you the best results, and it will decrease your headaches in the end. And then also, when you're treating someone with underlying dermal pigment, lower energies, lots of cooling. I am special, thank you. Okay, so this is my future mother-in-law's best friend's chest. And you can see here she has a little bit of redness and pigment. She also has a nevi. I did not treat that on the upper, her left, I believe. But you can see here she has redness. So she's a very light Fitzpatrick skin type. She's like a skin type 2. So I used the PR 530 on this area to try to get rid of that. So I'm going to go to the video. Okay, so this is the video. So you can see here, she has diffuse redness. When I press on it, see how it blanches? That means she has a lot of little capillaries feeding blood into the tissue. So I'm going to, okay, so you can either pick diffuse redness pigment or facial telangiectasias. I picked facial telangiectasia because I like the single energy delivery better. If you were concerned and it was your first time, it was your first patient, use the diffuse redness because that's going to be a gentle energy delivery. Whenever I'm treating off face, I will typically either lengthen the pulse duration or decrease my fluence accordingly. I usually, this is just for my V-beam days, shout out to V-beam, but I will use 3 milliseconds when I'm off face. So I use 3 milliseconds and then I decrease down to about 6 joules, I believe I did on this. And that's kind of my start. And that's, you know, that is a little bit of an aggressive energy delivery. So just something to know, if you're going to do that, you may want to consider decreasing to like 5.5. But I basically want to see the area blanch. So I pulse, I pick up, I want to see it blanch white or like even a little bit, well, it's really white. So you'll see here, I'm applying a thin layer of gel. I pulse once. See, I don't know, can you see that? You should be able to see it blanch white in the area of the applicator. When it blanches white, that's a really good indication that you have the appropriate energy delivery. Okay. So, hi, Tierney. When treating discrete facial vessels on darker skin types or to present darker purple in color, do you ever use the VL individual telangiectasia setting? And if so, what millijoules and pulse durations do you find effective? Okay, so I will be honest, I do struggle with the VL555 on individual vessels. I usually just use the recommended settings with the pulse duration and go up by 2. And I will be honest with you, if I don't see the clearance with that, I actually will cool with a cool compress. And then sometimes I will try to PR530 it, but I'll do it with the small, the hexagon pattern. I do find the VL555 a little bit tricky in that regard. I do find that I have to default to the PR530 or the 1064 in that case. How much pressure, hi Janelle, how much pressure do you apply? So, okay, when you're treating vascular, you don't, sorry, I got dark here. Is that, oh, now I look creepy. Okay. If you're treating vascular, you don't want to use a lot of pressure because you're going to push the target out of the way. So light pressure, a feather touch. If you're using, which if you had our old ELOS, that can, you have to learn that. That took me a second. If you're treating pigment, pressure is okay. Hi, Charlie. If it did not blanch, would you suggest increasing the joules only or both joules and pulse duration? Okay. Okay, if it doesn't blanch when you're treating diffuse redness, I would keep my pulse duration short at, okay, so I would either start it, okay, this is a great question. Sorry, I know what I'm trying to think of what I actually do because I'm kind of a mad scientist in there and it's not always, I just try everything until it works. I think what I would do first if I was off face treating diffuse redness is I would keep my pulse duration at 3 milliseconds, but I would go up to like 6.4. If I was treating on face, I think I'd actually do the opposite and they were a lighter Fitzpatrick. I think I'd drop down to 1.5 and then decrease my energy by 20%. Darcy says she would increase energy, which you can do that too. I mean, it really depends on, I guess it depends on the provider. You know, there's lots of different ways to get everywhere. Okay, so this was a full back treatment and the photo does not do it justice because she's a little bit of a tricky case where she has really bad rosacea. And she's like, kind of like, there's no better way to put this, but like her texture is rough and coarse. And she has kind of, it feels very rough to me. So I was like, what could I do for this patient that would work? So I did PR 530. She's a lighter Fitzpatrick skin type. And then I did 1550 and 1940. And her testimony, I don't need to like go into it, but it was like unbelievable. She had the worst texture on her back. Like you could touch it and you could feel it. And as soon as I did the 1550, 1940 IPL combination, it's like brand new baby skin. So something to think about it. And I did not prompt this. She like, I saw her and she told me all this and I said, can you email that to me? But she was like, when she wears her, I guess her kids are noticeable, as all children tend to be, and they would point out how scaly she was. And so when she did that treatment, the results were like unbelievable. And I just was very, very happy to hear that. Now, look, guys, one thing to think about with poikiloderma or any diffuse redness, there is a school of thought that you have to bruise them in order to get effect. So just something to know, if you're not seeing your results, you probably need a shorter pulse duration, or you need to increase the fluence until you see a little bit of bruising. I really don't like to bruise people because everyone says they're okay with bruising until it happens to them and they don't like it. So actually that's not true. I have one patient who does bruise, who I do bruise. And I will say she came in last week and her skin looks so good. But just something to know with that is, you know, you really need a short pulse duration on that. These are going to be your cherry angiomas. You can either use the PR 530 or the 1064 nanometers with that. It works, the YAG does work nicely, but just remember the safety, the therapeutic range on YAG is a little bit tighter than it is with other technology. Okay, guys, let's just talk real quick. If you're treating port wine stains, really try to avoid your 1064 nanometer at all costs, because the 1064 nanometer goes deeper into tissue, because it makes this methemoglobin formation, there is an increased risk of unwanted effects. So I don't even touch YAG on port wine. I would only use either the PR 530 or the VL 555. What's kind of interesting to think about with your VL 555, the energy delivery goes deeper into tissue. So you're able to treat the vascular lesions. You can kind of get all depths of the vascular lesion with that. So just some food for thought. I know, Christina, it is amazing. Port wine stains, like they just, when you see the results that you do, it's like life-changing. There's your hypertrophic scar. Vascular. Okay, so we're going to get into hair removal a little bit. So with hair removal, you can use these IPL handpieces. You're going to use typically the 600 nanometer IPL, and you can get really nice results with it. You do need to use gel, so it's a little bit of a slower treatment, but you can see that the results are really good. Now with clear nail, you're going to use your 1064 nanometer handpiece. Please wear please use a buffalo filter and wear a mask that filters to less than like 0.1 microns, I think it is. And it's usually like 4 to 6 sessions spaced at 4 to 6 week, 8-week intervals. You need to make sure that they bring clean socks, that their shoes are clean, and that they're using the topical antifungal powder. Warts. Okay. So here is my post care. If I'm doing Frax 1550 and Frax 1940, they're going to be puffy. It is what it is. Like I look puffy right now because it's hot in here. But anyways, they're going to be puffy. Use a hydrating, this says occlusive. Oh yeah. So, okay. That day, I usually just apply Elastin Nectar. I do like it. I know it's expensive, but I do like it. Or I just use thermal spray. The next day, I'm going to have them use a hydrating topical that is somewhat occlusive. So usually what I do is, actually Zio just came out with a new one. What is that called? Soothing ointment. And then you can do like a thin layer of Aquaphor over it. You don't start that to the next day because you don't want to hold in the heat. And then they can use ice packs. I'm like a little bit of Nurse Ratched when it comes to this. I really don't like them to use ice packs immediately post because I want the heat there, because I want to see an improvement. I want that heat to stimulate collagen. I'll let them do it maybe the next day if they absolutely can't handle it, but I try not to. Have them sleep elevated. Also, if they're really swollen under their eyes, you can have them mix a tablespoon of Epsom salts with 8 ounces of water. You put your little washcloth, clean washcloth in, they soak it, they lay it over their eyes, and it can draw the water right out. People say it's game changing. Dr. Shallon taught me that. I did not come up with that on my own. Your vascular lesion and your benign pigmented lesion treatment with the IPL handpieces, you're not breaking the stratum corneum. So as long as they're using gentle skincare post, they're fine. I do laser enzyme gel post, and then I just do zinc. I don't do zinc. Sorry, I should have said that. I don't do zinc though with Frax handpieces immediately post because it can actually irritate the skin.